Top Med Talk.
Hi, this is Desiree Chappell. Welcome to Top Med Talk. We have been covering the COVID crisis from the front lines, and we've continued to have conversations with providers all over the world about their experiences with COVID specifically, but also now shifting gears to kind of what we're going to be doing during the COVID crisis for scheduled surgeries, elective surgeries. We had a chance to catch up with one of our colleagues from New Jersey, Dr. Art Martella.
Great. Thank you for having me.
Can you tell us where you're from, what your background is?
I'm a cardiothoracic surgeon in actually Camden, New Jersey, which is just across the river from Philadelphia. We have a program here that before COVID, we were doing about 800 open heart cases, and we're actually right now in the middle of the surge. 2 or 3 cases a week, yes, right now. We seem to be having a slight uptick, but yes, that's about where we're at.
Is the community getting cases presenting with lung cancer problems? Because we seem to have a presentation problem here in London, not necessarily a throughput of patients. Patients seem to be avoiding the healthcare system in a way that they're not presenting for diagnosis.
Actually, that was a topic of discussion, and we have had a significant concern about where not just the lung cancer patients, but also our acute MIs, acute congestive heart failure patients that we would see in the emergency room. They would be getting urgent cardiac catheterizations. They have dropped off considerably, and originally we thought we would be seeing at least a very similar amount of those cases. And in my discussions with a few other surgeons regionally, they're experiencing the same thing. You know, basically, where are all of these urgent or emergency cardiac events that we were seeing? I think the feeling really is that people are really trying to avoid coming to the hospital. I think that those unstable angina symptoms that they were having they're not enough to bring them to the emergency room right now.
We have this we sort of think we've gone over our surge in London, we think. We don't know if we're going to get a second rise. But we now have this strange situation where we've got one advert says stay at home, and the other one says if you're worried, come to hospital. So it's managing those public health messages to say, if you found a lump, if you've got a pain in your chest, come on down, we're here to help.
Right.
Extraordinary times.
Agree. We're actually trying to do a little bit of self-marketing, so to speak, in that we want to try to create a safe environment and let patients know that there is this safe environment, that they can come in and not feel quite as worried that they're exposing themselves. But it is definitely a difficult process, and I feel like we're almost obligated to do marketing, to market the fact that we are putting these things in place to protect them.
It's almost like we need to make it part of the news briefings that, for, like our governor is still doing a daily news brief. And he's been very vocal about, stay at home for health, reasons to call your doctor. But I think we also need to put that message. If you are having extreme pain or anything along those lines, that you need to go to the hospital immediately. Like it's okay, right. It's safe. And to change that messaging, even through the news outlets, I think it'd be worth reaching out for sure.
There's enough people talking about the drop-off in cases that I think there is a health concern that people are really avoiding the hospitals at all costs. And I think we have to start at this point to reverse that a little bit and get patients who really need the care to get in and have it taken care of.
So just a couple questions. So you're a cardiothoracic surgeon, is that correct?
Correct, yeah. Mm-hmm.
So what kind of, how many cases have you been doing since the COVID crisis has been going on?
Well, we dropped off almost, I wouldn't say to zero, but we were doing maybe 3. We normally are doing about 700 to 800 hearts. We dropped off to doing maybe 3 cases a week. Wow. And now, though, we're starting to pick up, not because we've made any changes, but I just think there's starting to be more patients that may have put things off for a while that are now coming in who need surgery.
What are you doing as far as optimization goes for your patients? Like the ones that you're going to be bringing in, electively, but, you still need a little bit of time. Are you doing any major optimization for them since you have a little bit more time? So really optimizing like A1Cs or anemia or anything like that?
We actually are doing some of that. We created a spreadsheet of all our patients. First of all, to make sure nobody sort of dropped off the list, and fell through the cracks. And then also a sort of a scheduled calling in. And I've also actually been, sort of making sure they have a clear line of communication, even if it means giving them cell phone numbers, things like that. Just to make sure that they have that access, to feel that certain comfort level. And actually, people have been remarkably good about, only using it when they really need to. And then, but you're absolutely right. We've been trying to get them to continue to exercise, sort of having a walking, almost a prehab routine before their surgery.
Great. Yeah, that's what we've been talking a lot about. It's like we have this huge list, and wow, what an amazing opportunity we can take to actually get people a little bit more optimized. And do you do any kind of nutritional optimization for your cardiac patients?
We do. We've actually been trying to, it's hard under these circumstances to try to utilize that, but we have been trying to improve their nutritional status, make sure that their weight is at least being maintained. And some of our overweight patients, as you mentioned, the A1C, and really trying to have tighter control, similar to what we would do if they were in the hospital, trying to just get tighter control and maintaining a certain degree of activity.
Yeah,
so it's actually been pretty good. Some of our smoking patients, since we have more time, trying to get them to stop smoking, or at least certainly cut back.
I'm curious to know what other types of optimization strategies are you taking for your current cardiac patients and probably the ones before COVID, but to make sure that you optimize them to get them out of the hospital more quickly, because those are not patients that you want sitting around in your hospital.
For sure. We do a fair amount of non-sternotomy cases. So we're actually pretty aggressive with robotics for our coronary cases and some of our valve cases. And a lot of the ERAS protocol fits very nicely into that, because at the end of the day, these non-sternotomy or minimally invasive cases really comes down to the pain management and to some degree nutritional management and progression through their hospital stay on a slightly more aggressive pathway. And so we've been utilizing the Neurontin and Tylenol, and even more aggressive with pain management. We've been doing cryoablation in the OR for our intercostal pain. And actually, we're trying to do a study right now. We do ESP blocks. Anesthesia does ESP blocks on all our thoracotomies. And now we're trying to see if the cryoablation actually is making a difference in their long-term postoperative pain. There's certainly some questions that have arisen as to whether we might be actually aggravating the patient's pain in some cases with cryo. And some of our colleagues have backed off on utilizing it, but we've had some very dramatic pain management successes with cryo. So we're really trying to take a look at that a little more closely to see if we can figure out who may benefit the most from it. I think from the nutritional point of view, I think patient satisfaction point of view, it's all been very positive, and we've been pretty aggressive about implementing most of the ERAS protocol.
Mm-hmm. And I have one more question about hemodynamic management, and fluid management intraoperatively. I know that's always a concern in the cardiac space, especially whenever we're tending to dry patients out on bypass and things like that. Can you speak to that a little bit?
Yeah, that's been an interesting journey for me, because early on, I was very big on maintaining my patients dry. I was kind of against giving fluids, and that worked, I guess. At least I thought it worked. But in reality, every patient is different. And I think we've gone to this, almost reversal now, where patient comes into the operating room, sometimes even 24 hours before. We'll use the optimization, platform to try to really get their fluid balance perfect. I was so big on avoiding blood transfusions that I really didn't want to give a whole lot of volume. So I was really restricting the amount of volume anesthesia was giving. We try to use just 500 cc bags, really try to sort of work that side of the blood management. But really, there's some patients that are just dry when they come in, and they might need fluid. And if that drives their hemoglobin down, then maybe they do need a transfusion. But I think that's a process for me and for our program. But I think it's been a huge benefit for actually reducing our renal problems. And even I think just our early postoperative recovery, because they're not on as many drips, so a lot of that stuff allowed us to move our patients along quicker.
Because I know we've made a transition in how sick our patients are over the years, and the idea that there's a straightforward coronary is the sort of thing of the past. But, when I started off doing cardiac way back in the last century, sounds a long time ago now, the use of vasopressors and following that with the use of renal support because the patient's now got acute kidney injury. I don't know whether it's just romantic memories, but I don't remember it being that common. And then we seemed to go through a phase where it became almost common to come out on a vasoactive agent. Do you think it's all the patients, or is it a mixture of the two?
It's a mixture of the two. I agree with you. I've been doing this for a while also, and I agree. It was pretty frequent not to be on any inotropic support. Normal ventricle, take the clamp off, heart looks great, and just move along. But there also seems to be this much lower threshold to start a Levofed or just some sort of vasopressor agent, rather than maybe just optimizing their fluid balance a little bit. That definitely has been an issue for us. But I think the HPI particularly has really helped us manage the fluid balance much better.
So that's the use of the artificial intelligence to predict hemodynamic instability, which I haven't seen it used in cardiac surgery yet. I've used it a lot in very controlled situations. I think it's an exciting area. So what about the kidney, the removal of fluid on bypass, Art? Where do you stand on that? That seemed to become very fashionable as well.
It's the crit story, right?
A lot of that stuff was actually happening sort of behind the scenes during a case. Perfusion would take off sometimes liters of fluid, and sometimes they felt like they were doing the right thing, taking off this large amount of volume. But then we just found like we ended up being on more vasopressor support, giving volume back at the end, and there's these huge shifts in fluid balance that were going on. So we actually have tried to cut back on the amount of volume that we take off and do it in a sort of a measured way. And as a team sort of discussion about how much volume we're going to take off before we have another discussion about it. That has definitely been an issue for us.
Yeah. That's great. You guys have that conversation. I did cardiac for years as a CRNA. And I know it was like afterwards you'd look over at the can, you're like, oh my gosh, this is going to be terrible coming off the pump because I took off so much. And they're so hyperdynamic at that point. So that's great that you guys are having those team discussions. Definitely a lesson to be learned from that.
I don't think anyone says they know the right answer right at the moment. They know it's highly individualized and it's a new voyage of discovery. But we definitely have to look closely at it.
Yeah.
I think what you just said, though, that it's individualized is the key thing. I think having one plan, one idea that fits for all the patients, which I have to admit I had for a while, just doesn't work. I mean, it doesn't make any sense, really. And I think you really have to look at the patient. I mean, some of them are on diuretics. They're older. They've been NPO for a while. You can't fluid restrict some of these patients like you might somebody else who's volume overload.
Right. Yeah. And then most of them don't come in. Dr. Martella, thank you so much for this great chat. I think it's going to be really interesting moving forward as we are ramping up cases and getting things rebooted and started to continue to have conversations like this. I think it's great. So thank you for your time and good luck with the ramp up there and in New Jersey. I know we're all going to be extremely busy once this starts going again.
I agree.
Yeah.
Thank you. Right. Thanks for having me.
Top Med Talk.
Absolutely. Well, thank you for listening to Top Med Talk. And thanks to the healthcare workers, all of them on the front lines. Our hearts are with you during this unprecedented time. And for more conversations like this, you can find us at topmedtalk.com or on social media. We're on all your favorite platforms, Twitter, Facebook, LinkedIn. Again, please stay safe, stay well. We are all going to get through this together. Thanks for listening.
Top Med Talk is proud to thank its sponsors, specifically Edwards Life Sciences, for their generous support through this global crisis.